Imagine going to the pharmacy, to buy a product that promises to stop your physical pain, only to find out that because of just basic chemistry, it is actively tearing your cells apart.
Oh, yeah. It's wild. The shelves are basically lined with products that actively worsen the condition.
Right, and the people buying them have absolutely no idea.
None at all.
Well, welcome to the deep dive. Today, we are looking at a staggering statistic that honestly completely reframes how we think about aging and women's health.
It really does change the whole perspective.
Up to 84% of postmenopausal women experience genitourinary symptoms.
Yeah, 84%.
That is an overwhelming majority of half the population. But the real kicker here is that less than 10% actually receive any treatment.
It's just tragic, really. We are looking at this highly prevalent, highly treatable condition, yet the vast majority of people suffering from it are just trapped in total silence.
And that is our mission today. We are exploring the science of genitourinary syndrome of menopause, or GSM. But more specifically, we are diving into how clinicians and patients can constructively break through this massive wall of shame and the inadequacy regarding the body's changing natural lubrication and sexual function.
Because, this is so much more than biology. It is a profound communication breakdown.
Okay, let's unpack this. Where are we getting our information today?
So, we're pulling from a really robust stack of clinical sources. We have the latest clinical guidelines from the American Urological Association, consensus statements from the British Menopause Society.
Heavy hitters, basically.
Oh, absolutely.
Yeah.
And several fascinating studies on clinical communication frameworks. Specifically, we're looking at research on how healthcare providers can constructively address these feelings of inadequacy using models like PLISSIT.
Right, the PLISSIT model.
Yeah, which was recently utilized in this major type 2 diabetes clinical trial.
Well, before we tackle that communication gap, I want to establish what is physically happening in the body first.
Does that make sense?
Like, if you can't understand the physical mechanics, you just can't understand the psychological shame that follows.
Yeah, and a lot of the confusion and shame, historically, stems from the medical terminology itself, actually.
Oh, for sure.
For decades, the medical community used terms like vulvovaginal atrophy or atrophic vaginitis.
Just hearing the word atrophy sounds awful.
It really does.
It implies a personal failure,
Yep.
You just let a muscle wither away because you didn't use it or you didn't try hard enough.
Exactly. The term carries immense stigma, and it also falls short clinically because it misses the full picture of the syndrome. So in 2014, the medical community officially pivoted to the term genitourinary syndrome of menopause, or GSM.
Okay, GSM.
Right, and the key word in there is genitourinary. The condition doesn't just affect the vagina. It impacts the vulva, the bladder, and the urethra as well.
So we're talking about a whole regional system. What is the actual biological trigger for all this?
Well, GSM is a chronic progressive condition caused primarily by the steep decline in estrogen. And that's alongside a drop in other sex steroids, like androgens, during and after menopause. These hormones are essentially the maintenance signals for the tissues in the pelvic region.
So when those maintenance signals just stop, what are the actual symptoms a patient feels day to day?
It really covers a broad spectrum. The most common reports are severe vaginal dryness, burning, and itching.
Ouch.
Yeah. And then there is dyspareunia, which is the medical term for painful sexual intercourse.
Right.
Beyond that, the urinary symptoms are incredibly disruptive. Things like urinary frequency, urgency, and recurrent urinary tract infections.
Yeah, the UTI piece really stood out to me in the sources. It mentioned that some women are just put on endless, agonizing rounds of antibiotics for suspected UTIs.
It's super common. The underlying tissue becomes so vulnerable and irritated due to the lack of estrogen that it actually mimics a severe infection.
Wow.
Or, because the natural defenses are compromised, invasive bacteria easily take hold, creating a genuine recurrent infection that antibiotics just temporarily suppress.
As you're describing this loss of the maintenance signal and the resulting vulnerability, I'm picturing this whole microenvironment as a highly delicate rainforest ecosystem.
Oh, I like that.
Yeah.
Tell me more about how you see that.
Well, okay, in a healthy rainforest, it rains every single day, right?
Right.
That rain is estrogen. The estrogen keeps everything lush, and it feeds the local flora.
Exactly.
In the human body, that flora is the healthy microbiome, specifically lactobacilli bacteria.
Yep, the good guys.
Right, and these bacteria consume sugars in the tissue and produce lactic acid, which keeps the pH of the soil, the tissue, nice and acidic, like around a 3.8 to 4.5 on the pH scale.
Spot on.
And that acidic environment acts like a bouncer, keeping the bad bacteria out.
The biological mechanics align perfectly with that analogy, actually.
But then menopause hits and the rain stops. The estrogen just drops off.
Yeah.
Suddenly, the local flora starves and dies off. And because there's no bacteria producing lactic acid, the pH levels rise and the environment becomes alkaline.
The soil literally dries out.
Right. The whole ecosystem becomes incredibly vulnerable to irritation, micro tears, and those invasive infections you mentioned.
Exactly. Without estrogen, the tissue literally loses its structural integrity. Collagen production plummets, and the local blood flow decreases significantly.
That sounds so painful.
It is. The tissue thins out to the point where even basic friction from walking can cause microtrauma. What's fascinating here is that the physical exam findings don't always directly correlate with the severity of the symptoms a patient self-reports.
Wait, let me make sure I understand that. A doctor could look at the tissue, see that the rainforest is completely dried out, but the patient says they feel fine.
Yeah, or the exact opposite.
Really?
A clinician might perform an exam and see very mild thinning, yet the patient reports agonizing, burning pain.
Oh, wow.
The visible regression of the tissue just does not dictate the subjective experience of pain. This makes the patient's personal history and their own description of their symptoms the most crucial diagnostic tool.
So you can't just eyeball it.
No, a doctor cannot diagnose the severity of GSM just by looking.
Which brings us to the giant elephant in the room.
Yep.
If the biology is this clear, and 84% of postmenopausal women are dealing with this dried-out ecosystem, why on earth are less than 10% getting help?
Well, we're looking at a tragic combination of profound shame, societal silence, and a massive clinical disconnect.
Okay, let's start with the patient's perspective. The sources highlight that many patients mistakenly believe these changes, especially the loss of natural lubrication, are just an inevitable consequence of aging. They think, well, I'm getting older, so my body's just supposed to hurt.
Which is so heartbreaking. Society conditions women to believe that aging is synonymous with suffering, particularly when it comes to reproductive and sexual health.
Definitely.
But this transcends just physical discomfort. For many patients, the inability to naturally lubricate triggers deep internalized feelings of inadequacy.
Like they're broken.
Yes.
Yeah.
They feel a fundamental loss of their femininity, or they just feel fundamentally broken.
And that feeling of being broken ties directly into the sudden loss of libido. People often assume that when estrogen drops, the sex drive just biologically evaporates.
But it's not that simple.
Right. The sources suggest the mechanism is much more psychological.
It really is. The loss of libido often stems directly from the anxiety surrounding physical discomfort.
Makes sense.
If a patient knows that intimacy is going to result in burning, tearing, or lasting pain, their brain's threat detection system activates.
Like an alarm going off.
Exactly. The fear of pain actively suppresses sexual desire. The brain is literally trying to protect the body from trauma by shutting down the desire to engage in the act that causes the pain in the first place.
That makes perfect sense. The patient is scared, they're feeling totally inadequate, and they assume it's their own fault.
Yeah.
But what about the healthcare providers? Why aren't the doctors catching this?
Well, the research refers to this as a medical standoff.
A standoff.
Yeah. Our sources included a brilliant cluster randomized controlled trial focusing on patients with type 2 diabetes in primary care settings.
And diabetes is incredibly relevant here, right? Because it can severely impact blood flow and nerve function, which already complicates sexual functioning.
Oh, absolutely. Layering GSM on top of diabetic complications makes the patient feel entirely hopeless.
I can imagine.
So the trial revealed how the standoff happens mechanically. You have patients sitting in the exam room, far too embarrassed to bring up vaginal dryness or sexual dysfunction.
And the doctors.
On the flip side, the doctors are purposely avoiding initiating the conversation.
Wait, are the doctors just embarrassed too?
In some cases, yeah, they are. But the primary drivers are actually a lack of time and a lack of specialized training.
Time. Always time.
Always. A primary care physician typically has about 15 minutes to manage a patient's A1C levels, check their blood pressure, and review their cholesterol.
Right.
Bringing up sexual health feels like opening a Pandora's box.
Because if they ask...
If the doctor asks about sexual pain and the patient breaks down crying, the doctor doesn't have the 45 minutes required to properly unpack that. Nor do they feel equipped with the clinical tools to actually fix it.
The sources also brought up the critical necessity of trauma-informed care in these moments, too.
Yes, so important.
Like when a doctor is dealing with genitourinary symptoms, They're navigating incredibly sacred, sensitive territory.
They really are. A significant portion of the patient population carries histories of military sexual trauma, intimate partner violence, or childhood abuse.
That's a huge factor.
So now imagine a patient with PTSD in a standard rushed pelvic exam.
Oh, gosh.
They're already feeling a loss of control, the lights are bright, the clinical instruments are cold.
Yeah.
If a doctor bluntly asks, "Are you having painful sex?" or just rushes the physical exam, it can feel like an interrogation or a violation rather than medical care.
It can profoundly trigger the patient.
Exactly, causing them to disengage from the healthcare system entirely.
If doctors are afraid to ask, and patients are too ashamed to tell, aren't we stuck in a massive medical standoff? How does a clinician actually break the ice without making the patient feel more self-conscious?
Well, to dismantle that standoff, clinicians rely on structured communication tools designed specifically to neutralize that shame.
Okay.
And the most prominent framework in our sources is the PLISSIT model.
PLISSIT. P-L-I-S-S-I-T. I'm guessing that's an acronym.
You guessed it. It stands for permission, limited information, specific suggestions, and intensive therapy.
Ah, I see.
It is a stepped care approach to sexual counseling.
Okay, walk me through how this actually plays out in a doctor's office. Let's say step 1 is permission.
Right. The clinician initiates the conversation by asking a broad, normalizing question.
Like what?
Something along the lines of, many women experiencing menopause notice changes in their physical comfort or their desire for intimacy. Are you experiencing any changes you'd like to discuss today?
Oh, that's good. By phrasing it that way, the doctor takes the burden off the patient. The doctor is signaling, this is a safe space, this is a known medical issue, and you are not defective for experiencing it.
Yes, and once the patient grants permission to discuss it, the clinician moves to the second step, limited information.
Limited information, okay.
This is where the doctor explains why the symptoms are occurring, with the specific goal of alleviating the patient's guilt.
The sources refer to a microenvironment-informed practice framework here.
Right. Instead of telling a patient, your body is aging and your tissues are atrophying, the clinician reframes the symptoms entirely as an ecological shift.
They use the rainforest analogy.
Oh, do?
They explain that the hormonal weather patterns have shifted, so the microbial ecology has changed. It's an environmental change, not a personal defect.
Yes, and if we connect this to the bigger picture, reframing GSM from a narrative of losing your youth to a microenvironment shift fundamentally dismantles the patient's shame.
It changes everything.
It really does. You aren't losing your femininity. Your local tissue ecology is just adapting to a new hormonal climate, and medicine can help manage that climate.
The sources also mentioned an optional tool for this stage that I found brilliant.
Oh, the drawing.
Yes, especially for older patients who might not have the complex medical vocabulary to explain their pain. They use arts-based genital self-figure drawing.
It's such a great tool.
How does it work? Exactly.
So the clinician provides a simple, abstract line drawing of the pelvic region.
Okay.
The patient can physically point to or circle the exact areas where they feel burning, itching, or pain.
That completely bypasses the embarrassment of trying to find the right anatomical words out loud.
Exactly. It makes communication so much easier.
You know, as I'm conceptualizing this PLISSIT model, it feels less like a medical protocol and more like a gentle ramp.
I love that analogy.
Yeah, like you don't shove a patient off a cliff into an invasive pelvic exam or intensive psychological therapy right away. You just ask permission to talk about the weather in their ecosystem.
It systematically builds trust. And once that trust is established, and the shame is reduced through the limited information stage, the clinician can finally move to step 3, specific suggestions.
Specific suggestions. This is where we get to the actual treatments to solve the physical and psychological issues.
Right.
And the sources emphasize starting with non-hormonal first-line treatments for mild to moderate GSM, namely moisturizers and lubricants.
And the distinction between those two products is vital.
They aren't the same thing.
Not at all.
Huh.
Moisturizers are designed for regular daily use, regardless of sexual activity.
Okay.
They are absorbed directly into the tissue to mimic the natural baseline secretions of a healthy, estrogenized vagina. They maintain everyday comfort.
Got it.
Lubricants, however, are strictly for use at the time of sexual activity to provide immediate, short-term relief from friction.
Here's where it gets really interesting, going back to our nightmare scenario at the beginning of this deep dive.
Oh, yeah.
When a patient is too embarrassed to talk to their doctor, they often just go to the pharmacy and buy whatever lubricant is on the shelf.
Yep, they look for products that promise warming sensations, tingling, or flavors, completely unaware of the cellular chemistry involved.
The sources dive into the science of osmolality, which is essentially the concentration of dissolved particles like sugars or salts in a fluid.
Exactly.
The World Health Organization actually has strict guidelines on this. They recommend that personal lubricants have an osmolality below 1,200 milliosmoles per kilogram, and ideally right around 280 to 300.
Right, and they also need an acidic pH of 3.5 to 5.0 to support that healthy rainforest environment.
But the problem is,
Many popular over-the-counter lubricants are highly hyperosmolar.
meaning,
Their concentration of particles is drastically higher than the natural concentration inside human cells.
wait, so if a patient buys the wrong over-the-counter lubricant because they're too embarrassed to ask their doctor, a hyperosmolar product could actually draw water out of their cells and make the dehydration and tissue damage worse.
That is exactly what happens. It comes down to basic osmosis.
Wow.
Water always moves from an area of low solute concentration to an area of high solute concentration to try and create a balance.
Right, high school biology.
Exactly. So when you introduce a highly concentrated hyperosmolar gel into the vaginal canal, it literally sucks the water right out of the patient's vaginal epithelial cells to dilute the gel.
That is horrifying.
The cells rapidly dehydrate, shrivel, and the structural integrity collapses, leading to severe microtrauma and sloughing of the tissue.
The very product the patient bought in secret to stop the pain is actively ripping the water out of their cells and causing more damage.
It's a tragic irony. Yeah.
That is terrifying. It completely underscores why this conversation cannot be taboo. Patients need a medical professional just to navigate the pharmacy aisle.
Absolutely. And when non-hormonal options like proper isoosmolar lubricants aren't enough, the specific suggestions pivot to hormonal treatments, which are highly effective for moderate to severe GSM.
And what's the gold standard there?
The gold standard is low-dose vaginal estrogen.
Because it's applied locally, right? Like as a cream, a suppository tablet, or a flexible ring.
Exactly.
So it stays isolated in that local microenvironment. The sources highlight that the absorption into the rest of the systemic bloodstream is incredibly minimal.
Yeah, and that minimal systemic absorption makes it very safe for the vast majority of patients.
Are there other options?
Another fascinating option is vaginal DHEA.
DHEA.
Yeah, DHEA is an inactive precursor hormone. When it is applied locally, the vaginal cells themselves use their own internal enzymes to convert the DHEA into active estrogen and testosterone right inside the cell.
Oh, that's clever.
It is. It improves the tissue quality without flooding the systemic circulation.
What about patients who are physically unable or maybe just unwilling to use a vaginal application?
There is an oral medication called osbemifene. It is a selective estrogen receptor modulator. When taken orally, it travels through the body that acts specifically like estrogen on the vaginal tissues, thickening them and improving elasticity without acting like estrogen on other organs.
That's amazing. But the Plicit model isn't just about throwing a cream or a pill at the problem. The specific suggestions must address the psychological damage, too.
Because the brain's threat detection system is already firing.
Right, exactly.
The loss of libido, the fear, and those feelings of inadequacy don't instantly vanish just because the physical tissue starts to heal.
The brain remembers.
The neural pathways actively associate intimacy with trauma. So the guidelines strongly recommend integrating cognitive behavioral therapy, or CBT.
How does CBT actually rewrite that fear response for a patient suffering from GSM?
Well, when a partner approaches a patient for intimacy, the patient's sympathetic nervous system might immediately flare up in anticipation of pain.
The fight or flight response.
Yes. And this can cause the pelvic floor muscles to involuntarily spasm, a condition called vaginismus, which acts as a physical barricade, ironically causing even more pain.
Oh, a vicious cycle.
CBT helps the patient consciously recognize that automatic threat response.
Okay.
By identifying the maladaptive thought like, this is going to hurt and I am broken, the therapist helps the patient systematically decouple the partner's approach from the panic response,
Rewiring the brain.
gradually rebuilding a sense of neurological safety.
Yeah. Alongside CBT, the sources stress the importance of psychosexual counseling, too.
Very much so.
One profound suggestion really caught my attention. It said that sometimes the most effective medical advice a clinician can give a couple is to temporarily take all penetrative sex completely off the table.
It sounds counterintuitive, but it works.
How so?
Removing penetration instantly eliminates the performance anxiety. If the patient knows with absolute certainty that the act causing the pain is not going to happen, the brain stops firing the fear signals.
Ah, I see.
This allows the couple to focus entirely on non-sexual intimacy, communication, and rebuilding emotional trust, while giving the physical tissues the necessary time to heal via the estrogen or DHEA therapies.
And finally, if a doctor has gone through permission, limited information, and these specific suggestions, and the patient is still struggling, that brings us to the final T, implicit.
Right, intensive therapy.
What does that entail?
Well, it means the primary care physician does not have to be the ultimate hero. Intensive therapy simply means knowing when to refer the patient to a dedicated specialist.
Like who?
This could be a pelvic floor physical therapist to mechanically address the muscle spasms, or a specialized sexual medicine physician for complex hormonal profiling.
Basically, the primary doctor's job is just to open the door and guide the patient to the right room. So we've traveled from the biological reality of the aging vaginal microenvironment, the drying out of the rainforest, as we called it, through a massive societal wall of shame, to the empowerment of the implicit communication model, and finally into targeted, deeply effective cellular and psychological treatments.
It's a huge shift. The journey moves the patient from a place of isolated suffering to a state of complete, informed empowerment.
And speaking directly to you, the listener, why should you care about all of this?
It affects so many people.
Exactly. Whether you are currently navigating these changes, whether you will experience them in the decades to come, or whether you love someone who is dealing with this right now, knowing that genitourinary syndrome of menopause is a highly treatable medical condition and absolutely not an inevitable, shameful decline of aging is incredibly freeing.
It really is.
You do not have to just put up with it.
Medicine has the tools to manage the climate of that ecosystem. We just need the courage to ask for them.
So what does this all mean?
This raises an important question, actually. If our medical system can master this communication, the societal ripple effects are profound.
Think about it. If clinicians successfully normalize the physical realities of older women's bodies and seamlessly integrate sexual health into routine primary care using compassionate tools like Plicit,
Yeah.
could that fundamentally rewrite society's deeply ingrained, youth-obsessed definition of intimacy itself?
I think so. If we successfully remove the stigma of aging from the medical chart, we inevitably remove it from the bedroom.
Imagine what a world without aging-related sexual shame would actually look like. We'll leave you to ponder that one.